Welcome to the Iron Prescription Podcast with your hosts, Doctors Lynette and Stuart. We're both GPs and we're both personal trainers, though we do both jobs in very different ways. We chat about the best things you can do for your health and fitness, and along the way, help you to avoid wasting time on the things that really aren't. Thanks for listening. Hello.
Hello, how are you doing?
All right, I'm good. We have had a considerable number of sign-ups to our inner circle.
Fantastic.
Yeah, which
That's
is
really good. Yeah.
Slow but steady. So people are obviously finding the website and wanting to be part of the conversation, which was the whole point of creating it. So that's good. And we have chosen today's topic, haven't we, on the back of, I suppose, a request or a query from somebody you were talking to as a nurse practitioner?
Yeah. Yes. About the increase in people presenting on, we say, therapeutic cocktails for pain.
Okay. So we thought that talking about chronic pain would be a useful area to cover.
Yeah.
We can touch on the therapeutic cocktails that people end up on. That would be useful, but probably give it a bit of background as well.
Yeah, sure. Yeah.
And interestingly, my first question, not knowing the person who put it to you, is have they moved from working, say, in an acute setting, like an urgent care centre, into normal general practice?
Sadly, no.
Okay.
Yeah.
Because that would be quite a normal thing to be shocked by if you've
Yeah.
only worked in an acute setting to come into general practice and see, oh my goodness, there's lots of people taking lots of things for chronic pain. And where did this jigsaw begin?
Yeah.
But so that's not the case.
No, so she works at the emergency department, and because of the state that we find the NHS in, people are presenting to wherever they think they can get help. And unfortunately, that means that people are presenting with long-term chronic problems into emergency departments, and it's not the right place, but if you're the patient, it's a place, and you don't really understand the difference. But the point is, she was shocked by this standard cocktail that she seems to be presented with patients that just, it used to be patients would present, and we know this from the research, would present on SSRIs, and there was a huge amount of patients on SSRIs, and now that appears to be more on trend for chronic pain.
Okay, so let's dig into this.
Yeah.
Because unless you work in a healthcare setting, people won't necessarily have any sense of the scale of this issue. And I think it still shocks me now in terms of how people end up in this position and how poorly resourced we are for people with ongoing pain. It's probably worth defining what we talk about with chronic pain, because people might think that it's 2 weeks of that thing not getting any better, but it's not. If you want to describe to people what chronic pain is.
Yeah, so we have different settings. We have acute pain, which is, as you described, something that's happened in the last couple of weeks. And then we have ongoing pain, which is something that's lasted up to 3 months. And then 3 to 6 months, we jump over into this bracket called chronic pain and beyond.
Yeah.
And what we do know is if you get to 3 months with pain, the chances are that's going to be a long-term problem.
My experience of seeing people in this position is it can be from one part of the body.
Mm-hmm.
Let's take a back, for example. There'll be many people listening to this who've had what they would consider chronic back pain coming and going, and consider that to be one body part, although I'd argue there's probably lots of parts of the back that are all working together to produce these pain signals. But sometimes it can be pain in multiple sites, multiple joints, sometimes with a symmetrical pattern, sometimes, despite the best efforts, there's no pattern whatsoever.
Yes.
And I think it's important to say that what's going on in your physiology is quite different at that point, isn't it?
Yes, yeah. So I think the way I split it up is that there's pain that is localized to an area of distinctive pathology. What I mean by that is if arthritis of a knee, knee arthritis or hip arthritis, that's where the pain is coming from. It is ongoing because the process remains there and it's an ongoing process. So that's a specific area with a specific title. And then you get the rest of this chronic pain, which sort of appears to be not directly as a result of a single pathology per se. So it's not an arthritis, it's not a break or anything like that. And it's an indescript pain that is coming from multiple sources. Regardless, it is a pain that is disabling in its nature.
Yeah. And reaching for some ibuprofen or some cocodamol because you fell over last night and you tweaked your back or you landed on your knee is a very reasonable thing to want to do to alleviate the pain in that acute setting.
Yeah.
And any doctor will sometimes recommend that people go and do that, sometimes
Yeah.
before they've even had it looked at. There's not
Yeah.
always value in rushing off to get the ankle sprain looked at necessarily. But it becomes more complicated the longer it goes on and the less of a role there is then as time moves on for those, what we would call short-term anti-inflammatories or painkillers. Let's just keep it general and refer to painkillers in that instance. And that's partly to do with how the brain and the body together are moving on in how they produce pain signals. One of the things I tend to try and still do with patients if I've got time is explain the phenomenon that pain is actually an output signal by the brain, not an input signal. So the input to the brain can be a pressure signal, a thermal signal. If you keep your hand on the stove when it's hot, that's not a pain signal going into the brain. The brain sends pain out to get you to move your hand away from the hot stove. So pain is always an output by the brain, and feeding into that are different inputs. And when you're moving into the territory of ongoing chronic pain, there's often a lot more inputs going in than there is when you've just fallen over. Your mood is a significant input. Your beliefs are an input. Your state of tiredness and hydration, all these different small, subtle things can input into the brain and have an effect on the pain output signals that are coming out that you then interpret as pain. And I think most people will get that.
Yeah.
But it's helpful to set that out when we have to start using more creative combinations of medication to try and help people. Because nobody wants to sit in front of somebody who's in pain and feel like they've got nothing to offer. We've all been there. It's horrible. It's a horrible feeling as a doctor. But it's very complicated. If somebody has been given access to something like an opioid-based painkiller in an acute setting and it's worked very well, and they remember that it's worked very well, and you then say to them, but you're now 3 months into this pain or 6 months into this pain and it's not appropriate to keep using that morphine, it becomes quite a difficult conversation, doesn't it?
It does. I know this from myself, from the injuries I've had over the years, and it is incredibly difficult because even as a professional, painkillers do work, and you're reluctant to try and get rid of them, especially if you're in a position where you don't understand the pain. And I think that's something that's really hard for patients. The painkillers work. Well, why can't I just keep taking the painkillers? And of course you can keep taking the painkillers, but the reality is they aren't doing what they were doing before. So we know from, for example, with opiates, for people that don't know, the receptors for opiates are already part of your body. They're there, and it's a great painkiller because it's already designed to latch onto the body. But what we do is we make more receptors, and therefore the dose that you had at the start doesn't work anymore, and you need more and then you build more receptors, and then you need more, and it's a ever declining circle. And you can get to a state where people are on painkillers for incredibly long time. Now, I'm not averse to people being on painkillers for a long time, as long as what I find really difficult is when they start to get side effects. So they're getting all of the side effects and none of the benefits. But when you say, we need to stop these painkillers, they're like, no, I can't. Because it's like you said, have already been worn down by that pain, by the interruption in sleep, by the disruption in their lifestyle. And it's trying to navigate that and say, okay, for example, arthritis, I want you to do more on your knee, not less, when everything in your mind is saying, I just want to take painkillers and I want to be pain-free and I want to sleep a normal night and I don't want to do more exercise. And you're telling me I've got to do more exercise and it hurts me to do exercise.
And we're wired to avoid pain and
Yeah,
discomfort.
yeah, yeah,
It is the smoke alarm signal. I use that analogy quite a bit with people in that a lot of pain will be the smoke alarm, and thankfully there's not usually a fire. But you don't know initially. The natural inclination is to back off from pain. And sometimes people will say early on, I wanted something done and they just gave me painkillers and I'm worried that it might be masking the pain. And that's quite a valid argument. But actually, this is a valid argument when you're trying to buy 5 or 6 weeks to justify the MRI scan that the NHS
yeah,
is so reluctant to give
yeah,
out.
yeah.
So you need a bit of time to allow some healing to go on. Then there's a window where imaging may come into play.
Mm,
But then no sooner are you past that, then we're saying to people, "Oh, you need to be off these painkillers. You can have all sorts of problems down the
yeah,
road."
yeah, yeah.
But people get bounced around with all of it. And there are as well, going back to the cocktail analogy,
Mm-hmm.
there are some types of medications that are frequently used more and more now for pain control, which didn't even originate as painkillers. And I suspect it's the person that spoke to you about this, that's what she was alluding to in
Yeah,
the hang on a minute. So some of those will be epilepsy medication, they're quite frequently
yeah.
used. And these things tend to get discovered by accident in that they are working on the central nervous system for one thing, and they can have an inhibitory effect on a pain output
Mm,
signal that's going on. They end up being used outside of license, but seem to still be subject to the same complexity when they're ongoing
mm,
of tolerance, needing a bigger dose, and side
mm,
effects that come along.
mm.
I think it's worth adding as well that as people do less because of the nature of pain, they will decondition.
Yep.
Any instability around a painful body part is going to get a little bit worse, and an
Mm,
unstable joint that's painful is going to fire off
yeah.
much more readily than something that's well conditioned and stable and is still a little bit painful. So it feeds into this difficult situation that we've got of how to manage this moving forward and
Mm,
persuade the right term? Persuade somebody that actually, I know this is painful, but you're now at a stage where we need to start working through
mm,
this
mm.
if you're ever going to realize a future where you're not reliant on sometimes 6, 7, 8, 10 different
Drugs.
combinations of
Yeah,
drugs.
yeah.
Yeah.
I think as well, the other, it's okay to be in pain. No, I think it's people are, like you said, people are scared of pain.
Yeah.
It means one of two things that either there's something there, it's not getting worse because it's in pain in the chronic stage, not in the acute stage, but in the chronic stage, it's not getting worse from that perspective. Or there was something there and the body's remembering it
Yeah,
and
that's really important.
remembering the acute phase, which is different to something being there. So I think, and you alluded to there a minute ago about having an MRI. And this is the differentiation. We're going back to when I was saying about having pain around the body. So you've got a patient where you scan them and you go, that's the problem. I can see the problem. I know there's a problem from a physical point there. The bit that I find it difficult, because I can reassure somebody about that and say, okay, this is why this is happening, and this is why exercise will help. And you talked about stabilizing the joint, giving it strength around the joint, creating more space within the joint, those sort of things. But when somebody's got something like fibromyalgia, then it becomes much more complicated to explain that to somebody when all the test results that we have at the moment are normal.
Yep. And this is something that as a trainee, I hadn't really appreciated the scale of, because you learn about these chronic painful conditions. Fibromyalgia is probably the one we see most frequently,
Mhm.
but there are others in the mixture as well. Complex regional pain syndrome, I've seen a few of those.
Yeah.
There's several that come under this multi-joint chronic pain bracket. You learn about the theory on
Mhm.
paper, and then you start meeting people, and you meet more people, and you meet more people, and you start to see patterns. And that's what we do as doctors. We're
Yeah.
looking for pattern recognition. And people seem to go through this series of looking for a cause of the pain. Of course you would. You're in pain, you're looking for the cause, you're trying to get to the bottom of it. And we go through the investigations in a very systematic way: blood tests, physical examination, imaging when it's necessary, referral onto a specialist. When the specialist doesn't find anything and they send you back to the GP, they sit in front of you almost quite hopeless, unless they've been given a framework to understand their pain with a diagnosis like fibromyalgia. But they almost feel disbelieved. And I think that is really difficult. Some people will actually appreciate the diagnosis because they've got something to go away and look at and understand their symptoms by, and they find it quite helpful. And others, and I have to say, I've seen a gender discrepancy here in terms of most women are more willing to accept and recognize themselves within that type of a diagnosis, such as fibromyalgia. Less so with men, not 100% of the time, but I have had more male patients that have come back to me literally and banged their hand on the desk and say, I refuse to accept it. That's not me. I'm not one of those people.
And why is that?
Yeah.
Because, and it's quite, to me, it's very obvious. Men are, not all, but vast majority of men are not emotionally in touch with themselves. And this phenomena has a huge amount to do with the emotional self. Now, that doesn't mean, when I say emotional, people start thinking about somebody sort of in the corner rocking and crying and everything like that. I'm not talking about that. I'm talking about the way ourselves, not our physical self, but ourself exists in time and space. And that sounds a bit wishy-washy. But for a woman, I think they're much more attuned to that, and they understand that it's possible to have a bad day and not have a bad day the next day. But for men, it's all the same, isn't it? All days are the same. It's a very simplistic look, and there's some great benefits in that. However, it's also not a very helpful when you're in this situation, when you have to look a bit deeper into yourself and understand about what's going on. And we know that because some of the medication that you talked about anti-epileptics, antidepressants that we use for pain also appear to work on the psychological self as well.
I think as women, there was something my daughter said recently at 16 about men having a 24-hour hormone cycle and women having a 28-day hormone cycle. She got onto a bit of a rant about this because she's at that age. But if you think about that, by the time we hit midlife, women have had a lot more experience of feeling very different over the course of a month. You don't recognize yourself at some points of the month, and then 2 days later go, oh, I'm not quite sure why I was so dramatic about that 2 days ago, because now I'm back to normal. I can see that I look like a basket case. And we do get used to that to some extent. But men don't necessarily have that and are wired differently. I don't care whether that's unfashionable to say that, but the male brain is different to the female brain. They may have had a lot less cause to examine how the range of emotions can really impact on how you interpret things on a day-to-day basis. Doesn't mean it's not happening. It just means it's being processed in a different way. And at the risk of quoting yet another book, which I've read, which has been really, really quite eye-opening, and I would say, again, one of these turning points where I read it and thought, now a lot of things make sense. There's an amazing book called The Body Keeps the Score by Bessel van der Kolk. He is basically the trailblazer for doing the research on trauma and how it manifests physically in people. He set up a trauma center somewhere in America. He's one of a couple of people who've written books who came from, I would say he was a child of parents who were in the Holocaust. And I'm sure that has a significant impact on your journey and the things that you pay attention to. But when I read this book about how different things can manifest, sometimes years after experiencing a trauma in anybody, from a car accident to neglect to something much, much smaller T trauma. When you follow those people through over a lifetime, it leaves the scars, hence the title of the book, The Body Keeps the Score. And as I was reading this book, there were so many puzzling patients that I'd met over the years and worked with whose symptoms just suddenly made so much more sense to me that it was It's fantastic. I highly recommend anybody who is interested in this area give that book a look.
Yeah.
He's done the podcast circuit recently because he's been over in England touring, but it is absolutely fascinating, and it makes perfect sense because our brains are here to keep us alive. So anything that we process and take in and experience has got to be dealt with and put somewhere. And if we don't necessarily deal with it at the time, it will put it in a back shelf sometimes in the corner of your brain. But then at a later stage in life, you end up inadvertently opening that door and sometimes it comes out. And that's probably an extreme example, but that is going on for lots of people, lots of the time, on a lower level.
Yeah.
And I just wonder if the data shows that women are significantly more likely to be diagnosed with an inflammatory arthritis than men. I can't remember the ratio. I should have looked it up so that I had the data to hand, but I haven't. And it's widely talked about now that inflammatory arthritis, I don't know the plural, are often a consequence of unprocessed trauma or serial stresses throughout a period of life.
Yeah.
It's potentially the same thing that's going on. Whether they get that diagnosis or whether they get put in the chronic pain bracket, that's again part down to our services and how people are accessed through the system.
Yeah, I think that's a really interesting point because inflammation is the enemy of the body, and inflammation comes from all sort of external stressors, physical and psychological. And we know people that, for example, who have cancer as a result, in a lot of cases, from inflammation and chronic cellular stress. And that cellular stress has to come from a body stress, a grosser stress than the microscopic stress on the cell. And I think that is entirely right. It's that perception and how we react to those stresses. Interestingly, I think that with pain as well, when it comes coming back to sport, what you're doing is allowing your body to produce the same drugs but in more powerful concentrations. I think we forget about that when we're talking to patients. I try and reassure them that, yeah, you're getting a stimulus. Now the body will deal with that stimulus. I've been to huge amounts of patients in my role as a critical care HEMS doctor working on the helicopter who have acute, absolutely catastrophic injuries. And before I've given them pain, they're not in the pain you would expect them to be because the body has gone, I need to deal with this and I need to deal with it now. And it's releasing its own ability to compensate for that pain, whether it be turning fibers off or whether it be releasing internal endorphins to suppress the pain. We also know that from a less dramatic perspective, that doing sport does the same thing for people with chronic pain.
Funny, when you were talking there, I was just reminded of how my dog behaves when I take him to the vet. This is the power of expectation and psychology. He hates going to the vet. He absolutely hates it. And the last time he went, he yelped before she went to touch him, but before she'd even made contact.
Yeah.
He yelped in anticipation of God knows what he thought was going to happen. But we've seen this in patients, haven't we? When they're not necessarily, you've probably seen it much more acutely. Somebody perhaps isn't aware of the injury that's gone on as it's out of sight.
Yeah.
And then suddenly when they become aware,
boom,
yeah, all the pain comes flooding in. It's not a cliche, that is real.
The body is aware of the injury, the body's dealing with it. As soon as they put it into the frontal cortex and they bring it into their reality, the body is unable to deal with it anymore. You see this throughout life generally and how people perceive pain. And we've talked about this before. We talked about me doing the Manchester Marathon without any training, and you talk about people that are doing endurance events. Ross Edgley is just swim around Iceland, 1,000 miles around Iceland. That makes me feel pain just saying those words, let alone thinking about it in detail. But for him, his body has just gone, no, I'm not going to entertain that. And his perception of pain is different, and that's what we're talking about here. It's the way you perceive that pain. Now, I'm not saying I'm not saying he's not taking analgesia. I'm not saying that every ultra runner I know has a concoction of pills in their backpack to take because they need support. But when you try and put that into normal everyday life, people just go, I can't do it. And of course they can do it. You've got to allow your body to experience that.
Yeah, and it reminds me, a common thing that I've heard from many patients over the years is they reject this notion that it's all in their head. And it's worth remembering that all pain is in our head. Otherwise, how do you perform an operation where you take the head out of the picture using a general anaesthetic and you can chop a body up and sew it back together without any issue? Bring the head back into the picture, in comes the pain and the suffering.
Yeah.
So, and that's in order to just to illustrate the point that it's an output signal. Everything is interpreted through the mind. So it's not about just saying, oh, it's all in your head and not believing things. Pain is pain. Pain is real. Pain is
absolutely.
what you tell me it is.
Yeah.
But trying to open up a range of things to people as to what might be the exit plan from this. And none of it's quick. I know we want quick relief from pain, but if you're into that chronic pain territory, there's nothing out there. Is no one pill, apart from general anaesthetic, that is going to make you pain-free.
No.
It's got to be viewed as a process, a long one, and you have a significant role to play in how that process goes.
Yeah, absolutely. I can't stress the fact that being in pain is not always a smoke signal. That's the key to challenge. You've got to challenge the pain is the first step to being able to unburden yourself of that output signal. This is okay, and that's once all the patients I've had who've got to that point and they go, okay, I'm gonna try it. Now, they find that actually it's like they've been freed from that. They get a little pain, they stop, and they stop. But if you keep challenging it and go, okay, no, I get the fact I've got some pain, but I'm going to keep walking, then actually, because that output signal shouts less and then gets less and less.
Yeah. It's the dosing of that's the problem, I think. Yeah. One of the biggest disappointments I have in the services we've got to offer people, and that may just be representative of the region that we work in, is the pain clinic, because patients have an expectation that they'll go to the pain clinic and they'll cure their pain, and I always try and temper that before they go. But they have an opportunity to completely re-educate people as to what pain is. And I'm aware that some clinics do that quite well, but we don't have any on this patch. So people come away quite disappointed, having been offered sometimes some other drugs that they didn't get offered before, and invariably they're disappointed with that. Whereas actually the chronic nature of the speed at which this journey can be navigated to get out of pain could be put down, working slowly and surely to build what is essentially a rehab plan. Rehab is usually the way out of this. And I like the term rehab because it conveys the feeling of hope. Or convalescence, I suppose, is a more old-fashioned term that we don't tend to use anymore. But rehabbing something, and I've rehabbed people through back pain, and I'll say to them at the outset, this will be months. This is tedious, this is boring, but we need incremental progressions.
Yeah.
And if you follow the program and are patient, then you will come out the other side.
Yeah.
But I don't see that really happening in pain clinics. But then we could do a whole episode on things the NHS isn't doing that it could do better.
Yeah. I think they don't. I still don't think there's enough differentiation between you send somebody to pain clinic, and if they've got a reason, when I say everybody's got a reason to be in pain, but I'm talking about this focused, that's wrong, that's worn out example, that's why you're getting your pain, as opposed to a more generic type of pain, a chronic pain syndrome. It's understanding that we either have to have an operation, or the pain is going to remain, and we've got to manage the effect of the pain on your life. And to normalize, we've got to normalize the pain. We have to normalize where you're at and get away from this urgency. And I find that you've got that, and then you've got your patients with fibromyalgia that need to understand that fibromyalgia has much more multiple elements to it than a specific area pain. So there's lots more going on. And there needs to be a complete undoing of everything and a whole look at the person's being to understand what's happening with this and why they're having this. And we know, for example, CBT works really well. Talking type therapy, for people that don't know what that means. So a short period of talking type therapy works really well with people with fibromyalgia. And that's not just me saying it, that
the data's there.
Yeah. It won't work. CBT doesn't work for somebody with knee arthritis because they've got arthritis in their knee and they either need a joint replacement. And even if they have the joint replacement, I can't guarantee your pain's going to go away. Or we just need to manage the expectations of that, understanding what it is and accepting it and going, well, okay, we're just going to deal with it. It's just going to be there. It's an acceptance rather than trying to fight it all the time and get rid of it, because you're not going to get rid of it because it's there.
Yeah, I think that actually ACT therapy, I have a book somewhere on the shelf which talks about that, is a type of psychotherapy. Acceptance is something about accepting and moving on. It is a type of CBT that's well recognised. But again, you mentioned about having surgery for the knee, and I'm reminded about phantom limb pain. Again, another example I've used to illustrate to people how you can chop off a gangrenous foot, but there's nothing to say that person won't still receive pain signals, because as far as the brain's concerned, it's got this well mapped out area of a pain cycle that was going on for a long time before the amputation happened. And no amount of painkillers are going to necessarily remap that. It's a much more complicated process. But I think it's important to convey that it is possible. It's entirely possible to move out of the catchment and the zone of chronic pain, and I've seen it done.
Yeah.
But it's most successful when people are patient and they need to be really well supported. There's an entire back catalogue of confidence that needs to be rebuilt in what the body can do, that it's not going to let you down, it's not going to keep you awake all night if you go a little bit too far. And my experience of working with people with some sort of ongoing pain, especially if they've had a very active history, is they get into this tug of war with who they were before and the need to get back to that, because anything other than that isn't a full recovery. And that's where a lot of the support comes in, of going, okay, that was you then, in the same way that I'm not me of 10 years ago. We're building towards a newer version of you, but that's sometimes really complicated. You've done more work with people with high-level athletes than I have, but I've seen even where people have just played something to a competent level socially, it can be a real battle and a real barrier sometimes to moving through chronic pain.
It's interesting. I've got two types of clients when it comes to that. So I've got clients that absolutely fear pain and injury because they see that as the end of whatever they're doing. And the older that person gets, or those people get, the more likely they are to perceive it like that. If I get, this is going to strip away the performance that I've achieved over all this period of time. And then I've got other people, and I suppose I fall into this category a bit more, who almost see it like a badge of honor. I've broken so much in my body, but I see that as actually a life well led. And it does hurt. I do have, by definition, do have chronic pain, but it's that perception of what it actually is, isn't it? And what it means to you. And people say to me, I don't know if you should do that. And I'm like, I'm doing it, running, whatever, doing whatever. And they're like, oh, but what about that injury? I'm like, I'm doing it. Now, that's not me being gun-ho, and that's not me being, it's just me knowing that if I don't challenge pain, then I don't want it to erode what I am. So I'm just going to, and I accept the fact that it's not doing me any harm. It's not going to get any worse. This is as a result of long-term injuries, break things, dislocate things, etc., etc.
Yeah, it sounds like what you're saying is it won't become part of your identity.
No, absolutely not. I don't think it. I've been in situations where the pain has been, in the acute phases, has been absolutely horrendous, particularly with things like prolapsed discs. And we know that the worst thing you can do with a prolapsed disc is submit to it. And we both know a very well-known guy online who's a physiotherapist who, on online being videoed had a lower spine prolapse.
Oh yeah, Adam Meekins,
doing a deadlift, and then was absolutely smashed online by trolls when he was then said, just watch me work through this. Proof where the pudding is. I've said this works, I'm going to do it. And he did it. And I can assure you that the pain from a prolapse is horrendous. But the fact that he didn't stop and he didn't give into it is back to, where he was.
And of all the prolapse discs I've seen over the years, I don't think any of them have been done in the gym. That's not to say it doesn't happen in the gym, but they're usually moving furniture, I would say, is top of the league. Oh, I just needed to get that wardrobe from one room to the other, or it's life happens and these things happen. Absolutely. So the gym is your friend. It is not, it's not there to hurt you. But I think exercise, sport, rehab, moving, whatever bit of that continuum you want to put yourself on is such an essential part of the journey away from chronic pain that I can't recommend it enough. It really is. And I think even when surgery might be part of some sort of solution, not necessarily because it caused the chronic pain, but obviously people with chronic pain do go on to need new hips and knees as well, and need other bits replaced in that same way. And it feeds into what we've said before about whatever you can do beforehand is only going to improve your condition and your recovery, lower the chances of you going back in with complications. But it's finding the right dose and then being patient, because this boom or bust approach to, okay, I've had a good day today, so I'll do a little bit more, that doesn't fit with a rehab plan, really. And I think going back to the issue of the original question, why is this more prevalent? Why is being seen more in women more than anything else? It's complicated. It's emotional. There is a huge emotional factor, and that sadly is part of the reason women are unequally affected by chronic pain. They're probably less likely to be active compared to men. That's quite a generalization. I appreciate that might ruffle a few feathers, but in my experience, women get caught up doing other things in midlife, like raising a family, which means that their hobbies, particularly if they're sporting related, invariably will take a backseat. And that's not the sole cause, but it's another brick in the wall of the complicated things that feed into sometimes a chronic pain diagnosis that leads to the mysterious cocktail of drugs that these people end up on. And it's very hard to come back from. It is very difficult. And it's not appropriate to say, look, you're on far too many things. Let's just start knocking these off one by one. It needs to be done in partnership with patients at a pace that's right. I had a lady once who had just watched a programme about something on the telly about addicts, and suddenly looked at her cocktail of pain medication in a completely different light. And she came in and she said to me, I don't want to be on these things. Addicts are taking these things. And that is factually correct. And I think it took us about 2 years, but slowly but surely, because she was driving it, she got back down to zero. And I would say her pain was fairly constant across all of that. But we did it really slowly. But the key thing was she really wanted it. And it came from her. If I'd have tried to talk her into that, we'd have got nowhere. Absolutely.
And it's like I say, I'm not adverse to people taking tablets. What makes me sad is when people are suffering side effects as a result of taking the tablets, and you're like, the damage to your quality of life now is not only the pain, but as a consequence of you trying to escape the pain is actually worse than the pain. Opiates are a classic. If you're on too many opiates, you just lay in bed all day.
Yeah. And when you've seen that pattern a few times, I often say to people, nobody sets out wanting to become dependent on something. Nobody. They just want relief in that moment. But I have to protect you. And we have this conversation around Valium, diazepam, Jesus Christ, sleeping pills. It's a theme that comes up again and again, is that I'm genuinely trying to protect you from a complicated reduction regime down the line.
Yeah, absolutely.
Sometimes people are receptive to that. Other times you get the phone slammed down on you. And that's such is life. Good stuff. Good. I think we've covered most of the things that we wanted to cover. We are, of course, open to comments, suggestions and feedback, good or bad. Feel free to, if you feel like you want to be critical of what we've talked about, then absolutely, we're here for that.
Yes, indeed.
But other than that, we will consult with our inner circle.
Yeah.
Set up the topic for next time.
Yeah, indeed. Look forward to it.
All right. See you soon.
Yeah.